Welcome back, everyone. If you survived the RBC unit, congratulations, you've earned a gold star and probably a nap. Today we're making a big shift, leaving red blood cells behind and diving headfirst into white blood cells. This week is all about leukocytes, what they look like, what they're doing, and most importantly, what they're telling you. Your job, as a histotechnologist, is to read that evidence like a detective. So buckle up, because today we're going to build the foundation you need to do exactly that. We'll start with normal morphology, because you absolutely cannot recognize abnormal if you don't know normal. Then we'll move into reactive changes, left shifts, and the patterns that point toward infection and inflammation. It's going to be a wild ride. Before we move forward, let's take a 30-second victory lap. Over the past several weeks, you've learned how to interpret red blood cell pathology. You know what microcytic, hypochromic cells look like and what they mean. You can spot a schistocyte, a spherocyte, and a target cell. You understand the difference between intravascular and extravascular hemolysis. You've been thinking in terms of what happened to this cell. Was it destroyed too fast? Not made correctly? Missing iron? That's RBC thinking, and it's good thinking. But today, we flip the script. White blood cell thinking is fundamentally different, and making that mental shift is the first, and most important, thing we're going to do today. So get ready to change your perspective. Here's your roadmap for today. We're going to cover normal leukocyte morphology, all 5 major cell types. Then we're going to get into the really interesting stuff, reactive changes. What happens to a neutrophil when the body is fighting a serious bacterial infection? What does a lymphocyte look like when it's been activated by a virus? What does a left shift actually mean on a smear? We'll tie it all together by looking at response patterns, the characteristic pictures you'll see with bacterial versus viral infections. We'll even touch on seeing the organism causing the infection right there on the slide. By the end of today, you should be able to look at a peripheral blood smear and start asking the right questions. This journey into the WBC world is going to be eye-opening. This is the most important conceptual shift of the entire lecture, so I want you to really sit with it. When we look at red blood cells, we ask, what happened to this cell? But when we look at white blood cells, we flip that question entirely. We ask, what is the body responding to? The leukocyte isn't the victim, it's the responder. It's the firefighter, not the burning building. When you see toxic granulation in a neutrophil, that neutrophil is telling you something about what's happening in the patient's body. When you see reactive lymphocytes, those lymphocytes are activated, they're fighting something. The cell changes you observe are not random, and they are not decoration. They are evidence of a physiologic response. Keep that frame in your mind for the rest of this lecture, because it will make everything else make sense. This mental pivot is key to understanding WBCs. So why do we care so much about leukocytes in the clinical lab? Because they are, quite literally, the body's immune army. Neutrophils are the first responders, lymphocytes are the strategists, monocytes are the cleanup crew. Eosinophils and basophils play specialized roles. When you perform a manual differential and report what you see on that smear, you are giving the clinician critical information. Is there a left shift? Are there toxic changes? Are there reactive lymphocytes? A left shift, indicating an increase in immature neutrophils, often signals an acute bacterial infection or significant inflammation. 1. The presence of toxic granulation in neutrophils, characterized by dark, coarse cytoplasmic granules, further supports the diagnosis of severe infection. 2. Similarly, reactive lymphocytes are crucial indicators of an active immune response, frequently seen in viral infections. 3. That information directly influences whether a patient gets antibiotics, antivirals, or a bone marrow biopsy. Your eyes on that microscope matter. Don't underestimate that. This is why leukocytes are such powerful clinical evidence. Next, we'll dive deeper into how these cells provide that evidence. Every single morphologic change you observe in a leukocyte has a reason. These changes aren't random, they're the body's way of communicating what's happening internally. We just discussed how important leukocytes are in the clinical lab. Now, let me give you a framework that will serve you throughout your entire career. When you look at a peripheral blood smear and you see something unusual in the white cells, your brain should immediately go through 3 steps: identify, describe, and interpret. This systematic approach allows you to first identify the specific alteration, such as nuclear segmentation anomalies or cytoplasmic inclusions, then accurately describe its characteristics, noting size, shape, and staining properties, and finally, interpret its clinical significance in the context of the patient's overall health. 1. This is the difference between a technologist who just counts cells and one who actually reads the smear. Your job is to listen to what the cells are telling you. So, let's start by getting our baseline straight. I cannot stress this enough: you absolutely cannot recognize abnormal if you don't know normal. This sounds obvious, but it's the single most common reason students make errors on the differential. If you don't have a solid mental image of what a normal segmented neutrophil looks like, you're going to misidentify a band. We're going to do a quick but thorough review of all 5 major leukocyte types. For each one, I want you to think about 4 things: the nucleus shape and chromatin pattern, the cytoplasm color and texture, the granule type and color, and the normal reference range. For instance, a normal segmented neutrophil typically presents with a multi-lobed nucleus and condensed chromatin, accompanied by pale pink cytoplasm containing fine, specific granules, 6, 7. Recognizing these precise characteristics, down to the chromatin density and granule distribution, forms the indispensable baseline against which all potential abnormalities are evaluated. 8. These are your anchors. Memorize them. Before we dive into individual cells, let's get a bird's eye view of how granulocytes mature. Before we get into individual cell types, let's orient ourselves with the granulocyte maturation sequence. This is going to be critical when we talk about left shifts later. Granulocytes mature through 6 recognizable stages: myeloblast, promyelocyte, myelocyte, metamyelocyte, band, and segmented neutrophil. The myelocyte is the last stage capable of mitosis, and it's where the lineage is determined. During this progression, primary, azurophilic, granules emerge at the promyelocyte stage, followed by the appearance of secondary, specific, granules in the myelocyte, which are crucial for defining the cell-specific lineage. 1, 2. Concurrently, the nucleus undergoes characteristic changes, transitioning from a round shape in early stages to an indented metamyelocyte, a horseshoe-shaped band, and finally, the segmented form with condensed chromatin in mature neutrophils. 3. In normal peripheral blood, you should only see bands and segmented forms. Anything earlier than that is a red flag. Now, let's meet the most abundant white blood cell in your blood. Let's start with the most abundant leukocyte in peripheral blood, the neutrophil. These guys are the first responders. A mature, segmented neutrophil has a nucleus divided into 2 to 5 lobes connected by thin chromatin filaments. The cytoplasm is pale pink to tan, and the granules are fine and azurophilic. The nucleus to cytoplasm ratio is low, meaning the cytoplasm predominates. Neutrophils make up 50 to 70% of all white cells. Bands, the slightly less mature form, should be no more than 5%. Anything more than that, and you're starting to think about a left shift. Keep those numbers in your head. Now that you know what they look like, let's talk about what they actually do. Their primary role is phagocytosis, where they engulf and destroy invading pathogens, acting as a crucial component of the innate immune response. 1, 2. This destructive capability is largely attributed to their azurophilic, primary, granules, which contain potent enzymes like myeloperoxidase and elastase, essential for breaking down microbial invaders. 3, 4. Now that you know what a neutrophil looks like, let's talk about what it does. Understanding function helps you understand why morphology changes under stress. Neutrophils are the first responders of the immune system. When bacteria invade, neutrophils are the first cells to arrive at the scene. They phagocytose, or engulf, the bacteria, and then destroy them through degranulation and the respiratory burst. The respiratory burst is a critical process involving the rapid production of reactive oxygen species, ROS, like superoxide, generated by the NADP oxidase enzyme, which are highly effective in killing engulfed pathogens. 1, 2. This is why neutrophil granule changes are so significant. When you see toxic granulation, you're seeing evidence of an accelerated, stressed production process, where the prominent, dark granules reflect an altered synthesis of primary granules due to heightened demand during severe infection or inflammation. 3, 4. The neutrophil was made fast and deployed fast, and it shows. Next up, the lymphocyte, a small cell with a big role. Next up, lymphocytes. These are the second most common leukocyte in peripheral blood, making up 20 to 40%. Lymphocytes come in two flavors, small and large. Small lymphocytes are the most common. They have a round, dark, densely clumped nucleus and very scant pale blue cytoplasm. The nucleus to cytoplasm ratio is high, around 5 to 1. Large lymphocytes have a bit more cytoplasm and may contain a few eosinophilic granules. These are often natural killer cells or cytotoxic T cells. Both types have dense, clumped heterochromatin, which is one of the key features that distinguishes them from blasts, which have open, fine chromatin. This distinction is critical, as blasts typically exhibit a more immature appearance with fine, dispersed chromatin and often prominent nucleoli, unlike the mature, clumped chromatin of lymphocytes, even reactive ones. 1, 2. Now, here's something important to remember: lymphocytes are divided into B cells, which mature in the bone marrow and are responsible for antibody production, and T cells, which mature in the thymus and mediate cellular immunity. 3. You can't tell them apart on a Röntgen stain, you need flow cytometry for that. But on the smear, your job is to recognize them as lymphocytes and note if they look reactive. Let's spend just a moment on lymphocyte lineage, because it comes up in interpretation. B cells mature in the bone marrow and are responsible for humoral immunity. They produce antibodies. When fully activated, B cells transform into plasma cells, which are antibody secreting factories. You'll occasionally see plasma cells in bone marrow, and rarely in peripheral blood in certain conditions. The presence of plasma cells in peripheral blood, though rare, can be a significant indicator of conditions such as plasma cell leukemia or severe infections. 1. T cells mature in the thymus and mediate cellular immunity. They kill infected cells directly or coordinate the immune response. CD4 positive T cells are helpers, CD8 positive T cells are cytotoxic killers. NK cells are a third population. They're part of the innate immune system and kill abnormal cells without needing a specific antigen receptor. On a routine peripheral blood smear, you cannot distinguish these populations by morphology alone. However, flow cytometry utilizes specific CD markers, for example, CD19 CD20 for B cells, CD3 CD4 CD8 for T cells, and CD56 CD16 for NK cells, to accurately identify and quantify these distinct lymphocyte populations, providing crucial diagnostic information. 2, 3, 4. But understanding the lineages helps you interpret clinical context. For example, in infectious mononucleosis, the reactive lymphocytes you see are predominantly activated T cells responding to EBV-infected B cells. Monocytes are the largest circulating leukocyte, and they are wonderfully variable, which makes them both interesting and occasionally frustrating to identify. The nucleus is kidney-shaped or deeply folded, with loose, lacy violet chromatin, not the dense, clumped chromatin you see in lymphocytes. The cytoplasm is blue-gray with a characteristic ground glass appearance caused by fine, diffuse granules. Monocytes may also have pseudopods, little cytoplasmic projections, and vacuoles. They make up 3 to 11% of peripheral blood leukocytes. Here's the key clinical point: monocytes are the precursors to macrophages. When they leave the circulation and enter the tissues, they differentiate into macrophages, the heavy-duty phagocytes that handle chronic inflammation, engulf debris, and present antigens to T cells. This transformation into macrophages allows them to effectively clear cellular debris and pathogens, playing a crucial role in both innate and adaptive immunity. 1. Monocytosis, an elevated monocyte count, is associated with a wide range of conditions including chronic infections like tuberculosis, autoimmune diseases, and recovery from myelosuppression. Therefore, an increased monocyte count can serve as a valuable diagnostic clue, prompting further investigation into these underlying conditions. 2. Eosinophils are one of the easiest cells to identify on a smear. Those big, bright orange-red granules are unmistakable. The nucleus is typically bilobed, and the cytoplasm is cream-colored to colorless, packed with those characteristic eosinophilic granules. Normal reference range in peripheral blood is 0 to 5%. Functionally, eosinophils are specialists. Their primary roles are fighting parasitic infections, particularly helminths, and participating in allergic and hypersensitivity responses. These distinctive granules contain potent cytotoxic proteins, such as major basic protein, MBP, which are crucial for damaging the tegument of parasites and mediating allergic inflammation. 1.5. When you see eosinophilia on a differential, your differential diagnosis includes parasitic infection, allergic disease, asthma, atopic dermatitis, rhinitis, drug reactions, and certain hematologic neoplasms. The presence of elevated eosinophils, or eosinophilia, serves as a strong indicator for these conditions, guiding clinicians toward appropriate diagnostic workups for parasitic infestations or allergic disorders. 9.10. One morphologic note: eosinophils can sometimes appear hypogranular, particularly in hypereosinophilic syndrome or acute lymphoblastic leukemia. Also, eosinophils are fragile, they can rupture during smear preparation, so fractured eosinophils should still be counted as eosinophils in your differential. Basophils are the rarest granulocyte in peripheral blood. You'll see them at 0 to 1%, and sometimes not at all in a 100-cell differential. But when you do see them, they're hard to miss. The granules are large, dark purple-black, and they often obscure the nucleus. Here's a practical tip: basophil granules are water-soluble, which means they can wash out during staining. Sometimes you'll see a cell with a pale pinkish tinge and barely any granules. That's a basophil that lost its granules in the staining process. Don't let it fool you. Functionally, basophils are involved in IgA-mediated allergic responses. They release histamine and other mediators when activated. Their prominent granules contain potent mediators such as histamine, which contributes to allergic inflammation, and heparin, an anticoagulant that helps maintain blood flow at sites of inflammation. 1.2. Basophilia, an elevated basophil count, is classically associated with chronic myeloid leukemia, CML, which is actually one of the diagnostic clues for that disease. In CML, significant basophilia is not only a diagnostic feature but can also be prognostic, often indicating disease progression or a more aggressive phase. 3.4. It's also seen in allergic rhinitis, hypothyroidism, and chronic inflammatory conditions. We've covered the main circulating leukocytes, but before we move on, let's briefly touch on two special cells you'll encounter in specific contexts: plasma cells and macrophages. These cells don't normally hang out in your peripheral blood, but they're critical players in the immune system and important to recognize. Plasma cells are essentially antibody factories, the end stage of B-cell differentiation. They have a distinct look, an eccentric nucleus with coarse, clumped chromatin, often described as a clock face pattern, and abundant, deeply basophilic cytoplasm with a clear area near the nucleus, which is the Golgi apparatus. This prominent Golgi apparatus is indicative of their high metabolic activity in synthesizing and secreting large quantities of antibodies. 1.2. Macrophages are the tissue-resident form of monocytes, the ultimate cleanup crew. They're large, with a regular cytoplasm that often contains ingested debris, like old red blood cells or even microorganisms. Beyond mere phagocytosis, macrophages are crucial for antigen presentation to T cells, initiating adaptive immune responses, and orchestrating tissue repair after inflammation. 3.4. Seeing plasma cells in peripheral blood is a red flag. often indicating conditions like multiple myeloma. Now, let's quickly review the normal ranges for all these cells. Alright, let's hit the pause button for a quick review of the normal leukocyte reference ranges. You need to commit these numbers to memory, because they're your baseline for everything else we'll discuss. Segmented neutrophils should be 50 to 70% of your WBCs, with bands making up 0 to 5%. Lymphocytes are next, at 20 to 40%. Monocytes typically range from 3 to 11%. Eosinophils are usually 0 to 5%, and basophils are the rarest, at 0 to 1%. Any deviation from these percentages, either up or down, is clinically significant. Remember, an increase is aphilia or cytosis, and a decrease is apenia. It is crucial to remember that absolute counts are often more clinically informative than relative percentages, as a normal percentage can be misleading if the total white blood cell count is significantly elevated or decreased. 1, 2. Furthermore, physiological factors such as stress, intense exercise, or even the time of day can cause transient variations within these normal ranges, highlighting the importance of clinical context. 3. These ranges are your normal, your standard. Now, let's talk about what happens when the body isn't feeling so normal. Now we're getting into the really exciting stuff, reactive changes. Think of these as the body's way of talking back, telling you something is going on. A reactive change is a morphologic alteration in a leukocyte that happens because of physiologic stress. These aren't random, and they're definitely not malignant. They're the cell's response to infection, inflammation, or tissue injury. For instance, G-CSF therapy directly stimulates the bone marrow to rapidly produce and release neutrophils, leading to characteristic reactive changes as the body mobilizes its defenses. 1, 2. We'll primarily see these changes in neutrophils, which we call toxic changes, and in lymphocytes, which we call reactive forms. To report these, you usually need to see at least 2 of the classic features in the majority of cells. It is paramount for histotechnologists to accurately identify these benign reactive changes and differentiate them from early malignant transformations, as misinterpretation can lead to incorrect diagnoses and inappropriate patient management. 3, 4. Let's dive into the first of these toxic changes. First up in our toxic triad is toxic granulation. This is probably the most common and easiest to spot. You'll see dark blue-black, coarse granules in the cytoplasm of neutrophils. These are much more prominent than the fine granules in a normal neutrophil. They're essentially primary granules that have been supercharged to fight infection. One key thing to remember, the distribution is often uneven. You might see some neutrophils heavily granulated right next to others that look relatively normal. This unevenness helps distinguish it from some inherited anomalies. Toxic granulation is a loud signal, often associated with bacterial infections, sepsis, and severe inflammation. These prominent granules are rich in acid mucosubstances and are peroxidase positive, reflecting an accelerated and incomplete maturation process under stress. 1, 3, 13. It is crucial to differentiate toxic granulation from inherited conditions like Alder-Riley anomaly, where similar granules may appear in other leukocyte types and are not typically accompanied by a left shift or neutrophilia. 8, 10. When you see it, you know that neutrophil is working overtime. And often, where there's toxic granulation, there are also these next guys. Following on the heels of toxic granulation, we have DOL bodies. These are pale gray-blue, round or elongated inclusions in the cytoplasm of neutrophils, usually hanging out near the cell membrane. Think of them as little remnants of ribosomal RNA, essentially leftover rough endoplasmic reticulum from a cell that was produced in a hurry. It's like the cell was rushing to get to work and left its tools out. Ultrastructurally, DOL bodies are aggregates of rough endoplasmic reticulum, RER, containing ribosomal RNA, RNA, reflecting an accelerated granulopoiesis. 1, 3. DOL bodies are a sign of stress, appearing in bacterial infections, sepsis, pregnancy, and burns. They're not super specific, but they add to the picture of an activated, stressed neutrophil. Just be careful not to confuse them with the inclusions seen in Meheglin anomaly, which are also dough-like but are composed of precipitates of myosin heavy chain type Ia, MHC-Ia, and are typically associated with giant platelets and thrombocytopenia, a key distinguishing feature. 2, 4. Now, let's look at the third piece of the toxic triad. Our third toxic change is cytoplasmic vacuolation. When it's really prominent, the cytoplasm can look like Swiss cheese. Vacuoles are clear, unstained circular areas in the cytoplasm. They come in two types: large phagocytic vacuoles, where the cell is actively engulfing something like bacteria or fungi, and smaller autophagocytic vacuoles, where the cell is digesting its own components. Here's a critical point: in a septic patient, you might actually see organisms inside those large phagocytic vacuoles. That's a huge finding. But remember, vacuoles can also be an artifact. If blood sits in ETA for more than 2 hours before the smear is made, you can get autophagocytic vacuoles. So always consider specimen handling when you see vacuoles without other toxic changes. Context really matters here. Now, let's put all three of these toxic changes together. Now, let's put the three toxic changes together, because in clinical practice, you rarely see just one. Toxic granulation, Dohle bodies, and cytoplasmic vacuolation form what we call the toxic triad. To formally report toxic changes, you generally need to see at least two of these three features in the majority of neutrophils. The more severe the changes, the more severe the underlying infection or inflammation. A mild toxic granulation might suggest a moderate infection, but all three changes in most neutrophils points to a severe systemic process. Toxic changes almost always come with neutrophilia and a left shift, which we'll cover next. When you report these, you're giving the clinician a crucial piece of the puzzle. But before we dive into left shifts, let's quickly touch on some nuclear abnormalities. Before we move to left shifts, let's quickly cover two nuclear segmentation abnormalities you need to know. First, hypersegmentation, a neutrophil with 5 or more lobes. This is classic for megaloblastic anemia, where DNA synthesis is impaired, leading to abnormally large cells. You'll also see it in MDS and chronic infections. Second, hyposegmentation, neutrophils with fewer than 3 lobes but with mature, clumped chromatin. This is the hallmark of Pelger-Hewitt anomaly. The congenital form is benign and affects most neutrophils. The acquired form, pseudo-Pelger-Hewitt, affects fewer cells and is associated with malignancies like MDS. Here's the critical trap: Pelger-Hewitt cells can be mistaken for a left shift because the nucleus looks immature. But the key is the chromatin. Pelger-Hewitt cells have mature, coarsely clumped chromatin, while true immature cells have finer, more open chromatin. Don't let the nucleus shape fool you. Now, let's talk about the left shift. A left shift is one of the most important findings you can report, and it's often misunderstood. The term comes from old lab diagrams where immature cells were on the left side of the maturation sequence. A left shift means the bone marrow is releasing immature neutrophil precursors into the peripheral blood. These cells normally stay in the marrow until they're fully mature. Why does this happen? Because the body needs so many neutrophils that the marrow can't keep up with mature cell production alone. It starts releasing the reserves, bands, metamyelocytes, even myelocytes. Bands over 5% is an early sign. Metamyelocytes and myelocytes in peripheral blood mean a more significant left shift. If you see promyelocytes or blasts, that's a severe left shift, and you need to consider leukemia. This is a critical distinction. Let's explore why this happens. Let's talk about the mechanism behind a left shift. Normally, the bone marrow has a large storage pool of mature and nearly mature neutrophils, ready to go. When there's a severe bacterial infection, the demand for neutrophils skyrockets. The body signals the marrow to produce more, faster. The marrow responds by releasing not just the mature cells, but also the immature ones, metamyelocytes, myelocytes. This is the left shift. There's also a leukoerythroblastic reaction, which is a left shift plus nucleated red blood cells in the peripheral blood. This suggests marrow infiltration, like from metastatic cancer or myelofibrosis. It's a different clinical picture from a reactive left shift. The bottom line, a left shift plus toxic changes is a powerful combination that strongly suggests a serious bacterial infection or sepsis. Now, let's look at what this actually looks like on the smear. So what does a left shift actually look like when you're sitting at the microscope? Let's go through the cells you might see. Bends are the most common. They have a C, U, or S-shaped nucleus without a visible thin filament connecting the lobes. The chromatin is dark and coarse. Bands are normal up to 5%, above that, you're reporting a left shift. Metamyelocytes have a kidney bean-shaped nucleus with an indentation that takes up less than 1/3 of the hypothetical round nucleus diameter. Myelocytes have a round to oval nucleus, eccentrically placed, with both primary and secondary granules visible. Now, here's the practical challenge: distinguishing a band from a metamyelocyte from a Pelger-Hewitt cell can be genuinely difficult. The key is chromatin. Immature cells, bands, metamyelocytes, have progressively more condensed chromatin as they mature, but it's still somewhat open compared to a fully mature segmented neutrophil. Pelger-Hewitt cells have very mature, coarsely clumped chromatin despite their hypolobulated nucleus. When in doubt, note the chromatin pattern. Let's see how this combines with our previous discussion. Here's where we start connecting the dots into clinical interpretation. A left shift alone tells you the marrow is working hard. Toxic changes alone tell you the neutrophils are stressed. But when you see both together, a left shift with toxic granulation, dual bodies, and vacuolation, that's a powerful combination that strongly suggests a serious bacterial infection or sepsis. The severity of the picture correlates with the severity of the infection. Mild neutrophilia with a few bands and some toxic granulation? Probably a moderate infection. Significant neutrophilia with myelocytes and metamyelocytes, heavy toxic granulation, dual bodies, and vacuolation. That patient may be septic. Your report needs to capture all of this: the differential count, the degree of left shift, and the presence and severity of toxic changes. This information directly influences clinical management. Don't underreport. Now, let's take a detour into some conditions that can fool you. Now I want to take a detour into a group of conditions that are important to know precisely because they can be mistaken for something more serious. These are the inherited leukocyte anomalies, benign morphologic variants that have characteristic appearances on the peripheral blood smear. The big four you need to know are Pelger-Hewitt anomaly, Chediak-Higashi syndrome, Alder-Riley anomaly, and May-Heglin anomaly. Each one has a distinctive morphologic signature, and each one can be confused with something else: a left shift, toxic granulation, or dual bodies. Your job is to know the differences. Most of these are inherited, so they're not going away. Let's go through them one by one, starting with the most common imposter. Pelger-Hewitt anomaly is the most clinically important of the inherited anomalies because it is so frequently mistaken for a left shift. The mutation is in the lamin B receptor gene, which affects nuclear shape changes during maturation. The result is neutrophils with hypolobulated nuclei. They look like myelocytes or metamyelocytes, but with mature, coarsely clumped chromatin. The classic form is the bilobed pince-nez or spectacle-shaped nucleus. You can also see unilobed, homozygous, or peanut-shaped forms. In the congenital form, more than 68% of neutrophils are affected, and cell function is completely normal. These patients are clinically healthy. The acquired form, pseudo-Pelger-Hewitt, affects fewer cells and is associated with MDS, AML, and certain drugs including valproate, fluconazole, and ibuprofen. The practical implication: if you misidentify Pelger-Hewitt cells as bands or metamyelocytes, you'll report a false left shift, which could lead to unnecessary workup and inappropriate treatment. Always look at the chromatin. Next, we'll look at a rare but visually striking anomaly. Chediak-Higashi syndrome is rare. Only about 500 cases had been reported worldwide as of 2008, but it is visually striking and clinically devastating. The mutation is in the CHS1/LEAS gene, which encodes a protein involved in vesicle transport. The result is abnormal lysosome development, Granules fuse together within lysosomes, creating giant, abnormal granules that are visible in all leukocytes, neutrophils, monocytes, and lymphocytes. On the smear, you'll see large, dark, fused granules in the cytoplasm of all white cell types. These fused granules are dysfunctional, the cells cannot degranulate properly, cannot kill bacteria effectively, and have impaired chemotaxis. Clinically, patients present in infancy with partial oculocutaneous albinism and severe, recurrent, life-threatening bacterial infections. There are also bleeding tendencies because platelets are affected. The CBC shows anemia, neutropenia, and thrombocytopenia. Without treatment, hematopoietic stem cell transplant, most patients die before age 10. Let's move on to another granule anomaly. Alder-Riley anomaly is a great example of why context matters, because it looks so much like toxic granulation. This anomaly is part of a group of disorders called mucopolysaccharidoses, where the body can't properly break down certain complex sugars. These undigested sugars build up in the lysosomes of white blood cells, showing up as large, dark, metachromatic granules. Now, here's the trick: these granules look almost identical to the toxic granulation we discussed earlier. But Alder-Riley granules are found in neutrophils, monocytes, and lymphocytes, not just neutrophils. And crucially, you won't see dull bodies, a left shift, or neutrophilia, which you'd expect with true toxic changes. So, if you see these dark granules across multiple cell types, and the patient isn't showing signs of infection, think Alder-Riley. It's a permanent feature, not a temporary response. Now, let's look at another mimic, this time for dull bodies. Meheglin anomaly is another inherited condition that can fool you, this time by mimicking dull bodies. It's caused by a gene mutation that affects how certain proteins are made, leading to these large, basophilic inclusions in white blood cells. These inclusions look a lot like dull bodies, but they're not the same. Meheglin inclusions are made of precipitated myosin heavy chains, not ribosomal RNA, and they appear in all granulocyte types, neutrophils, eosinophils, basophils, and even monocytes. True dull bodies are usually only in neutrophils. The big giveaway for Meheglin, though, is the presence of giant platelets and often thrombocytopenia. So, if you see those large, blue inclusions in multiple white cell types, plus unusually large platelets, you're likely looking at Meheglin. Most patients are actually asymptomatic, but some might have mild bleeding. Now that we've covered these tricky anomalies, let's shift our focus to another important reactive change: lymphocytes. Reactive lymphocytes are one of the most exciting findings on a peripheral blood smear, because they tell you the immune system is actively engaged in a fight. You'll hear them called many things: atypical, variant, transformed, or even downy cells. But the key message is that these are activated lymphocytes, usually T cells, responding to some kind of antigenic stimulation. They're not malignant, they're just doing their job. They're a diverse bunch, so they won't all look exactly alike. You'll see variations in their size, nuclear shape, and how their cytoplasm stains. One of the most classic features, and a real help in identification, is cytoplasmic molding. This is where the cytoplasm appears indented or pushed in by the surrounding red blood cells, almost like the lymphocyte is soft and squishy. It's a telltale sign that this cell is activated and ready for action. So, let's dive deeper into what these activated cells actually look like. Let's get down to the nitty-gritty of what makes a reactive lymphocyte stand out. These cells are typically much larger than your average small lymphocyte, often ranging from 10 to 30 micrometers. Their nucleus can be irregular, sometimes kidney-shaped or even indented, and you might even spot a nucleolus or two. The chromatin can vary, sometimes appearing a bit coarser or more dispersed than a resting lymphocyte. But the cytoplasm is often the star of the show. It can be pale blue, or it can be a striking, deep basophilic blue, sometimes with a darker rim around the edge, which we call peripheral basophilia. You might also see occasional vacuoles or even increased azurophilic granules. And remember that cytoplasmic molding we just talked about. That's a key feature. When you see a large, irregularly shaped cell with abundant, often deeply basophilic cytoplasm that looks like it's being squeezed by its neighbors, you've found a reactive lymphocyte. Now, let's explore what triggers these fascinating changes. So, what gets these lymphocytes all fired up and looking so reactive? The most common culprits are viral infections. Think Epstein-Barr virus, which causes infectious mononucleosis, or cytomegalovirus, hepatitis, and even acute HIV. But it's not just viruses, other strong antigenic stimulations, like organ transplantation or certain drug reactions, can also trigger this response. Infectious mononucleosis is the classic example, where you can see more than 50% reactive lymphocytes on the smear. Now, it's important to note that not all lymphocytosis means reactive morphology. Some bacterial infections, like toxoplasmosis or brucellosis, can cause reactive lymphocytosis. But then you have conditions like Bordetella pertussis, or whooping cough, which causes a huge increase in lymphocytes, but they look perfectly normal. This is because the pertussis toxin keeps them in circulation, not because they're activated. So, always consider the clinical context. Next, we'll dive into the classic case of infectious mononucleosis. Infectious mononucleosis is the textbook example of reactive lymphocytosis, and it's a condition you will absolutely encounter in clinical practice. The causative agent is Epstein-Barr virus, which preferentially infects B lymphocytes. The reactive lymphocytes you see on the smear are primarily activated T cells responding to the EBV-infected B cells. The classic presentation is the triad of pharyngitis, fever, and cervical lymphadenopathy, most commonly in young adults aged 15 to 25. The CBC shows leukocytosis, absolute lymphocytosis, and up to 50% or more reactive lymphocytes. Complications include hepatosplenomegaly, which is why you should never give a mono patient a contact sport clearance. Now, let's talk about how we actually diagnose this in the lab. So how do you diagnose infectious mononucleosis in the lab? The peripheral blood smear is your first clue. You'll see a heterogeneous population of reactive lymphocytes with that characteristic basophilic skirting and cytoplasmic molding by RBCs. The rapid screening test is the heterophile antibody test, or monospot. It's quick and inexpensive, but it can be negative early in the infection, and it's often negative in children under 4 years old. For definitive diagnosis, you use EBV-specific serology. One important caveat: cytomegalovirus can cause a mononucleosis-like syndrome with very similar clinical and laboratory features. If the monospot is negative and the clinical picture fits, CMV serology should be ordered. Now, let's shift gears and talk about quantitative changes, when the number of leukocytes goes up or down. Let's shift gears and talk about quantitative changes, when the number of leukocytes goes up or down. Neutrophilia is an absolute neutrophil count greater than 7.5 times 10 to the 9th per liter. The most common cause is bacterial infection, but it's also seen with inflammation, stress, and steroids. Neutropenia, a count below 1.8 times 10 to the 9th, is more concerning. Severe neutropenia below 0.5, called agranulocytosis, carries a significant risk of life-threatening infection. Causes include viral infections, drug reactions, and aplastic anemia. Drug-induced agranulocytosis is particularly dangerous, with a mortality rate of 10 to 16%. If you see severe neutropenia on a CBC, it needs to be flagged immediately. Next, we'll look at lymphocyte count abnormalities. Lymphocytosis in adults is an absolute lymphocyte count greater than 5.0 times 10 to the 9th per liter. In children, the threshold is higher because they normally have more lymphocytes. Reactive lymphocytosis with morphologic changes is most commonly caused by viral infections like EBV, CMV, and HIV. Non-reactive lymphocytosis, with normal-appearing lymphocytes, is seen with Bordetella pertussis. Persistent lymphocytosis in an older adult with small, mature-appearing lymphocytes should raise concern for chronic lymphocytic leukemia. Lymphocytopenia, below 1.0 in adults, is associated with HIV/AIDS, immunosuppressive therapy, and chemotherapy. Severe lymphocytopenia is a significant immunocompromised state. Let's quickly cover the other leukocyte count abnormalities. Eosinophilia, above 0.4 times 10 to the ninth, is most commonly caused by parasitic infections and allergic diseases. It's also seen with drug reactions and certain hematologic neoplasms. Basophilia, above 0.15, is classically associated with chronic myeloid leukemia. Persistent basophilia is one of the diagnostic clues for CML. Monocytosis, above 1.0 in adults, has a broad differential including chronic infections like tuberculosis, autoimmune diseases, and recovery from myelosuppression. Profound monocytopenia is a classic finding in hairy cell leukemia, which is a useful diagnostic clue. Next, we'll look at how these patterns help us distinguish between bacterial and viral infections. This is one of the most practically useful slides in this entire lecture, so I want you to really internalize this comparison. Bacterial infections and viral infections produce fundamentally different patterns on the peripheral blood smear, and recognizing these patterns is a core clinical skill. In bacterial infections, the predominant response is neutrophilic. You'll see neutrophilia, an elevated neutrophil count, along with a left shift and toxic changes. The body is deploying its bacterial killing machinery. In viral infections, the predominant response is lymphocytic. You'll see lymphocytosis with reactive lymphocyte morphology. The body is activating its adaptive immune response. This distinction is not just academic, it has direct clinical implications. Your accurate reporting of these patterns directly influences patient care. Let's see how these patterns play out in the real world. Now, I have to give you the honest caveat, patterns are not always clean. The real world is messier than the textbook. While the previous slide gave us a nice, neat comparison, sometimes things get a little blurry. Early in a bacterial infection, you might actually see a relative lymphocytosis before the neutrophilia kicks in. Severe sepsis can paradoxically cause neutropenia if the marrow becomes exhausted. And some bacteria, like Bordetella pertussis, cause lymphocytosis rather than neutrophilia. The pattern is a guide, not a rule. This is why clinical correlation is so important. The smear tells part of the story, and your job is to put it in context. So, how do we approach this complexity systematically? Let's talk about case-based thinking. So, how do we navigate these sometimes messy patterns? Let's put together a systematic approach to smear interpretation. When you sit down at the microscope with a peripheral blood smear and a CBC, here's the framework I want you to use. Step 1. What is the total WBC count? Is it elevated, decreased, or normal? Step 2. Which cell type is driving the change? Is it neutrophils, lymphocytes, monocytes, eosinophils? Step 3. What morphologic changes are present in those cells? Toxic changes? Left shift? Reactive lymphocytes? Step 4. What pattern does this suggest? Bacterial? Viral? Allergic? Malignant? Step 5. Does it fit the clinical picture? This 5-step framework will serve you in every clinical scenario you encounter. It's not about memorizing every possible diagnosis, it's about asking the right questions in the right order. Let's try it with a case. Let's walk through a case using our new framework. A 45-year-old patient presents with fever, chills, and hypotension. The CBC shows a WBC of 18.5. The manual differential reveals 78% segmented neutrophils, 12% bands, 3% metamyelocytes, 5% lymphocytes, and 2% monocytes. On the smear, the majority of neutrophils show 3+ toxic granulation, Dole bodies, and cytoplasmic vacuolation. Applying our framework, WBC is elevated. The predominant cell is the neutrophil. There is a left shift and significant toxic changes. The pattern is classic bacterial infection, and the severity suggests sepsis. The clinical correlation. The blood culture came back positive for Staphylococcus aureus. Your smear findings were consistent with and supportive of that diagnosis. This is exactly what we mean when we say morphology is evidence. Now, for a different kind of infection. Now let's look at a viral case. A 19-year-old college student presents with sore throat, fever, and swollen lymph nodes. The CBC shows a WBC of 14.2. The manual differential reveals 12% segmented neutrophils, 2% bands, 68% lymphocytes, of which 55% are reactive, and 8% monocytes. On the smear, you see a heterogeneous population of large, irregular lymphocytes with deeply basophilic cytoplasm showing peripheral basophilia and cytoplasmic indentation by surrounding RBCs. Applying our framework, WBC elevated. Predominant cell, lymphocytes. Morphologic change, reactive lymphocytes. Pattern, viral infection. The clinical picture is classic for infectious mononucleosis. The monospot came back positive. Your smear findings told the story before the confirmatory test came back. That's the power of knowing what you're looking at. Sometimes, you even get to see the actual cause of the infection. Alright, we've reached the bonus section, and I genuinely love this part because it's one of those moments where the smear becomes almost cinematic. Occasionally, when you're scanning a peripheral blood smear, you will see the actual organism causing the infection. Right there. On the slide. This is rare, but when it happens, it's a powerful and direct finding. The key principle: intracellular organisms, organisms found inside leukocytes or red blood cells, are significant and essentially rule out contamination. Extracellular organisms alone are more ambiguous and could represent contamination, particularly from N4 line. So when you see organisms, always note whether they are intra or extracellular, and always correlate with the clinical picture. Let's look at the main categories. The most clinically important intraerythrocytic parasites are Plasmodium species, the cause of malaria, and Babesia species. Malaria is transmitted by the Anopheles mosquito and is a global health emergency, with hundreds of millions of cases annually. On the peripheral blood smear, you'll see ring forms, trophozoites, schizonts, and gametocytes inside red blood cells, depending on the species and stage of infection. Plasmodium falciparum is the most dangerous species. It causes cerebral malaria and has the highest mortality. Key morphologic clues: banana-shaped gametocytes and applique forms, where the ring is at the very edge of the RBC. Plasmodium vivax causes enlarged RBCs with Schuffner stippling and large, amoeboid trophozoites. Babesia species can look very similar to P. falciparum ring forms, but there are important differences. Babesia lacks pigment, hemozoan, has no life cycle stages, and characteristically forms the Maltese cross or tetrad form, 4 merozoites arranged in a cross pattern, which is pathognomonic. Travel history is your best clinical differentiator. Beyond parasites, you can occasionally see bacteria and fungi on the peripheral blood smear. Anaplasma phagocytophilum and Ehrlichia chafensis are tick-borne intracellular bacteria that form characteristic clusters called muruli, from the Latin for mulberry, inside leukocytes. Anaplasma infects neutrophils, Ehrlichia infects monocytes. These muruli can be mistaken for dual bodies in neutrophils, so careful examination is important. Cases of ehrlichiosis and anaplasmosis have been increasing in the United States, and early detection is critical because doxycycline is highly effective if started early. Histoplasma capsulatum can be seen as small yeast forms inside neutrophils and macrophages in severely immunocompromised patients. Cryptococcus neoformans, a large, encapsulated yeast, can be seen in peripheral blood in severely immunocompromised patients, particularly those with AIDS. And in septic patients, you may occasionally see bacteria, bacilli or cocci, inside vacuolated leukocytes. This is a significant finding that should be reported immediately. We're in the home stretch, and I want to bring everything together with the most important concept of this entire lecture, the interpretive step. Any technologist can learn to identify cells. Any technologist can count a differential. But the truly skilled histotechnologist goes beyond identification to interpretation. Interpretation means asking, What does this pattern mean for this patient? It means not just reporting 3+ toxic granulation but understanding that this finding, combined with a left shift and leukocytosis, is telling a story about a serious bacterial infection. It means not just reporting reactive lymphocytes but recognizing that in a 20-year-old with a sore throat, this is almost certainly infectious mononucleosis until proven otherwise. Interpretation requires knowledge, which is why we spent the first half of this lecture on normal morphology. It requires pattern recognition, which is why we went through the bacterial and viral response patterns. And it requires clinical correlation, which is why you should always look at the clinical notes when you're reviewing a smear. You are not just a cell counter. You are a diagnostic professional. Before we wrap up, let me briefly touch on congenital immunodeficiency disorders, because they represent the extreme end of the leukocyte dysfunction spectrum. There are more than 350 primary immunodeficiency disorders, each caused by genetic abnormalities that disrupt normal immune function. The most severe is severe combined immune deficiency, SID, in which both T cell and B cell immunity are profoundly impaired. Without treatment, most SID patients die within the first 2 years of life. Treatment is hematopoietic stem cell transplantation or, experimentally, gene therapy. Viscott-Aldrich syndrome is an X-linked combined immunodeficiency with T cell, B cell, and NK cell dysfunction, plus thrombocytopenia with small, abnormal platelets. DiGeorge syndrome results from a 22q11 deletion that causes thymic aplasia and T cell deficiency, along with cardiac defects and hypocalcemia. Bruton's agammaglobulinemia results from BTK gene mutation, causing absent B cells and hypogammaglobulinemia with recurrent bacterial infections. On the peripheral blood smear, these conditions may show cytopenias and specific morphologic findings depending on the syndrome. The key takeaway: when you see unexplained cytopenias in a young patient, especially with recurrent infections, think primary immunodeficiency. Chronic granulomatous disease is a fascinating condition because it reminds us that what you see isn't always the whole story. Here, the neutrophils look perfectly normal on the smear, but they're functionally broken. This genetic mutation means these cells can't generate a respiratory burst, so they can't kill certain bacteria and fungi. Patients get recurrent, life-threatening infections, even though their white cells look fine. It's a great example of why functional tests, like the DHR flow cytometry, are sometimes needed to get the full picture. This also highlights that morphology is just one piece of the diagnostic puzzle. As we wrap up today, let's look ahead to where we're going next, because it builds directly on what we've learned. We've focused on reactive changes today, things that are transient and a response to stress. But what happens when the cells themselves go rogue? That's the world of hematologic neoplasms. The big question you'll always be asking is this reactive, or is it malignant? Clues like blast in the peripheral blood or a persistent, unexplained cytopenia will be your red flags. Next time, we'll dive into leukemias, lymphomas, and myelodysplastic syndromes, and your understanding of normal and reactive will be your foundation. Let's do a quick recap of the absolute essentials from today. These are the facts you need to know cold, because they're your baseline for everything else. Remember your neutrophil percentages and their classic 2 to 5 lobed nucleus. Lymphocytes are smaller, with that dense, dark nucleus and scant cytoplasm. Monocytes are the largest, with their kidney-shaped nucleus and ground glass cytoplasm. Eosinophils are unmistakable with those bright orange-red granules, and basophils are rare but memorable with their dark, obscuring granules. And don't forget that granulocyte maturation sequence, anything earlier than abandoned peripheral blood is a big deal. Now for the reactive changes, these are your bread and butter for interpreting infection and inflammation. The toxic triad of toxic granulation, dual bodies, and vacuolation screams bacterial infection. A left shift means the bone marrow is calling for backup, pushing out immature neutrophils. Reactive lymphocytes, those large, basophilic, heterogeneous cells, are your sign of a viral fight. Remember the classic patterns: bacterial means neutrophilia, left shift, and toxic changes. Viral means lymphocytosis and reactive lymphocytes. And watch out for the mimics, Pelger Hewitt, Alder Riley, and May Heglin. Knowing these will save you from misinterpreting a benign anomaly as something serious. And here's the final thought I want to leave you with today. Every single cell on that peripheral blood smear is a piece of evidence. It's telling a story about what's happening inside that patient. Your job isn't just to count cells, it's to read that story. You're the detective, putting together the morphology, the counts, and the clinical context to form the full picture. The patient on the other end of that smear is counting on your expertise. So take it seriously, stay curious, and never stop asking, what is this body trying to tell me? I'll see you next week, when we start talking about what happens when the story turns malignant.